Lung cancer is still one of the major causes of death in the United States and across the world. Metastasis is the most common cause of lung cancer than primary diseases. Primary diseases are divided into bronchogenic or other causes. Bronchogenic carcinoma is the most leading cause of cancer death in the world. It also is increasing in incidence, especially in women. The risk factors for bronchogenic carcinoma include tobacco smoking, industrial exposures, granulomatous infections and scarring, as well as asbestosis. The classifications of bronchogenic carcinoma include squamous cell, adenocarcinoma, small cell, as well as large cell. The pathology of bronchogenic carcinoma is very detailed. It normally begins in situ cytologically with atypia over some unknown period of time. It may extend to the pleural surface and then to the pleural cavity and into the pericardium. It also can spread along lymphatics as well as hematogenous spread into the pathways. Several sites of metastasis from the lung include liver, brains, and bone. This slide is a demonstration of a bronchogenic carcinoma, including the airways. Squamous cell carcinoma is usually seen in male smokers. It is central and arises normally in the larger airways and larger bronchi. It commonly is cavitary and can spread locally. One thing of note is squamous cell carcinoma is known to cause hypercalcemia with a PTH-related protein. Adenocarcinoma. This is less linked to smoking. There are two major types, bronchial-derived or bronchial-alveolar. Bronchial-derived is normally a carcinoma around a scar. Bronchial-alveolar is multiple densities on X-rays mimicking pneumonia. Adenocarcinoma is normally peripherally. The most common type of lung cancer in women and non-smokers is adenocarcinoma. Small cell carcinoma is undifferentiated and highly malignant. It has the highest mortality rate out of all the lung cancers. It is linked to smoking and cannot be cured by surgery. Normally, there is an oat cell or spindle-shaped cells, and small cell carcinoma is also normally found centrally. With small cell carcinoma, you can have a paraneoplastic syndrome, including SIADH, as well as increased ACTH production. Large cell carcinomas are normally large, polygonal, with vesicular nuclei, with undifferentiated and normally found in the periphery. Neuroendocrine tumors are also something that can be found in the lungs. Normally, the most common kind is carcinoid. Bronchial carcinoid are normally found in patients younger than 40, and they can have a differentiation in their neuroendocrine cells, including Kolchitsky cells of the bronchial mucosa, which resembles intestinoid carcinoids. The clinical features of pulmonary carcinoid include a persistent cough, hemoptysis, and they can also have carcinoid syndrome. Usually they are polypoid and in the major bronchus. In terms of local effects of tumor spread, it can cause multiple problems in the patient. Primarily, pneumonias and abscesses are normally found when you have obstruction of the airways. Pleural fusions also can be found, which are commonly bloody. Hoarseness is a common complaint with recurrent laryngeal nerve invasion. Dysphagia, as well as diaphragmatic paralysis, is something also that lung cancers can do. If the lung cancer is invading the cell wall, you can have rib destruction. SVC syndrome is a compression of the superior vena cava that can be caused by local effect of the tumor. This will cause facial swelling, cyanosis, as well as dilated head and neck veins. A Pancoast tumor normally causes ptosis, meiosis, and anhidrosis, secondary to the involvement of the cervical sympathetic plexus. And this is normally seen in the lung cancers in the apices of the lung. Pericarditis as well as cardiac tamponade can be seen when there is pericardic involvement. When you have a paraneoplastic syndrome, there's multiple issues that can occur. If your cells are producing ADH, you can have hypernatremia. which is normally seen in small cell cancer. You can also have ACTH secreting cells, which can cause a Cushingoid syndrome. This can be seen in small cell as well. Squamous cell carcinoma normally causes hypercalcemia when you have a PTH-related peptide-releasing hormone. Lambert-Eaton myasthenia syndrome is normally seen when you have muscle weakness caused by these autoantibodies, and this is directed against the calcium channels. When patients have a perineoplastic syndrome, they can also have peripheral neuropathies, acanthosis nigricans, as well as osteoarthropathy. Horner syndrome, as previously stated, can be seen by ptosis, meiosis, anhidrosis, and enophthalmos. Pleural diseases. In reviewing pleura, we need to recognize where the pleura is innervated. Recognize that peripheral pleura is innervated by intercostal nerves, as well as the phrenic nerve and autonomic intervention. When we have pleura, we both have visceral pleura and the parietal pleura. The visceral pleura is around the lung, the parietal pleura is around the chest wall, and there is the potential space between the visceral and the parietal pleura. This example of this slide demonstrates the difference between the parietal pleura and the visceral pleura, as well as this slide. Inflammatory pleural effusions. Common causes of pleural effusion include tuberculosis, pneumonia, lung infarcts, lung abscesses, as well as bronchiectasis. When a patient has an empyema, they might have a purulent pleural exudate. Normally, you'll find a yellow-green creamy pus when you've done a thoracentesis. This is normally mixed with leukocytes as well as masses of neutrophils. Uncommon causes of pleural effusions include rheumatoid arthritis, lupus, and radiation-induced pleural effusions. Hemorrhagic pleuritis is commonly seen in rickettsial diseases, neoplasms, as well as hemorrhagic diatheses. Non-inflammatory pleural effusions is normally seen when you have hydrothorax, Meg's syndrome, hemothorax, or cryothorax. Hydrothorax is normally caused by heart failure and you have a serous fluid collection. Meg's syndrome is when you have hydrothorax, ascites, as well as ovarian fibroma. Hemothorax is when you have blood in the pleural cavity. This can be caused by iatrogenic causes with thoracentesis or central venous catheter placement, or it can be caused by pneumonias such as staph or a neoplasm. Chylothorax is when you have accumulation of milky fluid in the lymphatic area that leaks into the pleural space. A pneumothorax is a definition of air or some type of gas between the visceral and the parietal pleural cavities. This can be spontaneous, traumatic, or therapeutic. Mesothelioma. As mentioned before, within lung cancers as well as asbestos exposure, this may arise from either the visceral or parietal pleura. The most common risk factor is smoking as well as asbestos exposure. Mesothelioma is normally a diffuse lesion that spreads widely in the pleural space. With malignant mesothelioma, you can have a severe intraparenchymal disease, but primarily you have a thickened pleural surface with severe disease. This ends this section.